coming back. And I think it's quite probable that we will see this virus coming back in different waves over a number of years.
UCL and London School of Hygiene and Tropical Medicine researchers argue that fully reopening schools in September and parents returning to work without an effective test and trace programme could trigger a second wave. Do you personally agree with these findings, and do you think schools are adequately prepared in terms of contingency planning for a second wave or even localised lockdowns?
Well, I don't, again, depending on the definition of second wave, I don't think schools are going to trigger a second wave. But any measures that you release could allow a recurrence of the first wave, as it were. I think everyone, including the representative of the London School of Hygiene and Tropical Medicine on SAGE and the modellers from there, believe that schools are relatively lower risk than other things in terms of opening. One of the important areas that we need to look at is to make sure there's enough room for schools to open, because we absolutely know that there are risks to keeping schools shut. So I think SAGE, the modellers, and the consideration from the subgroup that we've got working on schools is very clear that we think that reopening schools is a priority. It's important for children. The President of the Royal College of Paediatricians, again, Russell Viner, has been clear that there are unwanted health and both mental and physical health problems with keeping schools shut. And schools, for the reasons I've said, children are at lower risk, and actually teachers are more likely to be at risk from other adults and sitting in small coffee rooms and so on with other adults than they are from the children themselves.
Thank you. I'm just going to ask some questions just about the app. So in a committee session that we had on the 24th of April, Professor Whitty said that contact tracing done the old-fashioned way, i.e. not using an app that takes a lot of the heavy lifting, is unbelievably labour-intensive to do. Do you agree, and how can a test and trace system effectively work without an app?
Well, contact tracing is very labour-intensive, and it exactly goes back to the point I made earlier on, that the test and trace system, or the tracing system that was in place actually in February, was not one that we didn't like. We wanted more of it, but it was very difficult to scale that on the basis of what Public Health England was able to do at the time. The app can help. I think a well-designed app that works, you could imagine, could help. Just worth reflecting, though, that the modelling that's been done suggests that if 30% of people were using it, you'd roughly have a 9% increased detection rate. So, you've got to get very high levels of use in order to get significant effects, which is obvious, because what you're trying to do is to pick up those contacts which you wouldn't pick up from memory, but you'd pick up because your phone or whatever told you were close to somebody. So I think there is an absolutely a role here, provided this can be done properly. And it hasn't been easy anywhere. I mean, the idea that lots of people have got great apps working on this is not correct. I mean, they've got some aspects of great apps working.
Just my final question. The NHS has spent £11.8 million developing and testing the NHS X app. It's faced technical problems, severe delays, and was eventually abandoned. We've also seen £32 million handed to a pest control company to source surgical gowns, and £16 million in April to get antibody tests from China that were shelved because they didn't work accurately. I appreciate this isn't a scientific question, but do you share my concerns on how public funds have been used during this pandemic?
That sounds like a question for the Secretary of State for the HSC to me.
Fortunately, he's coming on Tuesday, so I'm sure Zara will ask that. Patrick, do you think people should no longer work from home if they're not vulnerable or living with vulnerable people?
I think my view on this, and I think this is a view shared by SAGE, is that we're still at a time when distancing measures are important, and of the various distancing measures, working from home for many companies remains a perfectly good option, because it's easy to do. I think a number of companies think it's actually not detrimental to productivity, and in that situation, absolutely no reason I can see to change it.
We have discussed the importance of the indirect effects through the economy.
Yes.
And the Governor of the Bank of England is reported to be concerned about people working from home. companies may be able to manage with it, but if their workers are at home, they're not in shops and cafes and using public transport. Has that been part of your assessment in making this
we haven't been asked specifically to look at that question, but it clearly is part of the assessment, and that's where the integration of the economic, business and science comes together, and I've certainly been involved in those discussions.
It's urgently needed, isn't it, that assessment?
Sorry?
It's urgently needed, that assessment.
That is exactly what's going on in Cabinet Office with Treasury, and those things are fed into the decision-making process.
Right. So outside SAGE...
That's not SAGE can't advise on that. So SAGE's advice would be on the principles is in a way quite easy, which is the likelihood of the spread of the virus is dependent on contacts. Mm-hmm. So the more contacts you have at close range, the more likely this is to spread. And that principle underpins a lot of the advice. Then clearly the decision, for all the reasons we've talked about, including the economic impact of this and the impact of that on health, need to be integrated in terms of final policy decisions.
But that assessment, the economic impact, is relevant to lives and health. So is it right that should not be part of SAGE, that SAGE should just look, as it were, at the transmission and not at the health consequences of some of the measures?
So we do look at, as I said, and again, I'll go back to CMO, I think has been absolutely clear about this from very early on. The health impact of lockdown and measures we consider, but not in a modelling sense. We're not modelling that. We can't, because we don't have the economic modelling. But that is done, and that is then integrated at a Cabinet Office level in terms of the people around the table, which usually or always includes either CMO, me or both of us, or other scientific representatives to make sure the epidemiology and the other side of it is properly understood in relation to the business and economic decisions that need to be made.
I see, thank you.
But I think it would be wrong to think that that's a way that SAGE should do that. I think it's going to become a very big distraction to what SAGE needs to concentrate on.
Well, as long as someone's doing it.
Yeah, it is being done.
Yeah. Catherine McKinnell.
Oh, hello, hi. Sorry, I've just come back on. I've totally lost all connection, so thank you. I'm really sorry that I've just missed the bit just before.
Do you want me to go back
here.
to you,
so
Catherine?
if I repeat something somebody said, I apologise. I'm very grateful to be here. There are a huge number of petitioners interested and concerned in this issue, so it's good to be here in that capacity to represent some of their concerns. I wanted to follow up on some of the questions that Zara was asking about the track and trace system, and I'm really sorry though that I missed the answer that you will have just given about the app and taking some of the heavy lifting out of the old-fashioned way as Professor Whitty described it. And I wanted to explore how, in the absence of an app, we maximise our ability to track and trace, because it clearly is one of the most important things we can do to get ahead of the virus now. And so it would be helpful to understand from you what level of data we need to have available to the local public health. And I know this is a responsibility of Public Health England, but just in terms of the data, if you could explain how we ensure that the track and trace system is as effective as possible in the absence of an app that would be doing some of that work for us.
So two different questions in there. I'll just repeat what I said about the app. I think the app is an important potential part of this, but it's worth remembering if you had 30% of us all using it, you'd increase the number by about 9%. So we shouldn't think of the app as the answer to the problem. I'm afraid there's some rather boring, old-fashioned boots on the ground type thing that needs to happen in contact tracing, which is what's happening now, and the app would be a supplement to that and a useful one were it able to be fully functional, and it's not easy to get these things fully functional anywhere in the world. So that's the first point about that. So I've slightly forgotten the other part of the question now.
No, so the question is
the data flow.
In order to maximise those boots on the ground, so to speak. Yeah. As you said, it was very effective when the local public health teams were able to do what they do, and they do it very effectively in tracking down public health issues, and they were doing that in relation to coronavirus. And obviously it then became a much larger, and it needed to be scaled up, which is why then it became a national effort. And there's now 18,000 track and traces. The problem seems to be, and this seems to be coming from a number of directors of public health, that the two don't seem to be working together necessarily, and so you're not getting the adding up together of national ability to track and trace with local intelligence that's really vital for understanding how best to tackle it in local areas. So I wondered if you could comment on that.
Well, I strongly agree that this is a very important thing to get right locally, and the information flows need to be right. And the new Joint Biosecurity Centre is set up precisely to try and make sure that the data flows are there and they work and they get out into where they need to be, which is the local areas. And you're quite right that the local public health teams and local public health directors are absolutely critical in this, because we've moved from a stage of thinking of blunt lockdown across the whole population to being able to release some of those and then rely on much more local action. And local action can be as local as this one building needs to be looked at.
Yeah.
That requires really good information flows, and it requires Public Health England on the ground, and it requires JBC to be linked to that. And I know that's what people are working on, and those are very key operational matters to get right.
Thank you.
Yeah, and we're not there yet. And I think one of the challenges is that the level of data that's being provided is at postcode level. I think that's as granular as it gets. But even if you live at the same postcode, you don't necessarily attend the same church, you won't have been to the same swimming pool, you won't go to the same pub. And so the ability to actually get ahead of this virus does seem to be hampered by the data at the moment.
I agree, and it's the granularity of that data, and things like where you live isn't necessarily where you work, and those sorts of bits of information are really important.
Thank you.
And the speed as well. Sorry.
Thank you very much, Catherine. Graham Stringer, and then Erin Bell, and then Catherine Fletcher.
Thank you. Can I just, I've got some questions on testing. Can I just ask a couple of questions on your previous answers? Right at the beginning, you talked about the problems in care homes. Was it, and that was discussed at SAGE, we were told right at the start of this epidemic that if this bug got into care homes, we were likely to get 30-40% deaths in the care homes based on evidence from Washington State in America. Did you do a risk analysis? Most of the reasons given for not providing better protection have been about testing in asymptomatic people. But was there not a risk analysis done at the start of this process?
That's really a matter for DHSC. I mean, it's not a scientific question.
Well, why?
Well, we flagged up that care home. They have the accountability for that sector. And so, again, SAGE is not the organisation that manages these things. We can give science advice. I'm not asking
a management question, Sir Patrick. I'm asking a question about understanding what the risk might be. That's a data question. It's a question about understanding what potential damage might be done.
Oh, sorry, I misunderstood. I thought you meant risk assessment of care homes. In terms of literally going and do a risk assessment, which is...
No, I wasn't individually.
No.
I was talking... Professor Ferguson told us, again, right at the start of this process, that care homes weren't part of his models.
Right.
They didn't go down to that level of granularity. What I'm asking you, given that it was known, and amongst advisors, that this would be catastrophic, and we've had 25,000 deaths. Why wasn't a general risk analysis done so that policy options could be put forward to say what would be the best way of ameliorating this risk?
Well, I think there were... I mean, on the first point about models, the reason they're not in the models is they didn't have the data. So the data were not available from care homes to put into models. And that comes back to my general point about data, because you can't model something if you haven't got the data. And then in terms of was risk identified, risk was identified, and there are papers showing that the risks, the sorts of risks, and again it comes back to some basic principles such as people working between care homes is a risk, imported cases are a risk, spread within care homes are a risk. So those principles of risks were described, and therefore those are things that need to be taken into account. And you can see this was clearly the case, by the way, right the way across Europe.
But there were no policy decisions. There was no action taken, was there? I mean, what were the recommendations? We know there was a risk. We were told if the virus got into care homes, there were likely to be very many deaths. But there seemed to be no process between knowing that basic fact and people on SAGE and scientific advisors saying, right, if that happens, what policy options are we going to recommend to government?
We don't recommend policy options.
Well, I don't want to fence about words, but what advice we can give to government?
I've just listed some of the advice we gave, and I think how that is utilised is not a responsibility of SAGE. Now, we give the advice is laid out clearly, the advice is in the public domain, people can see the advice that we've given in these matters, and then it's a matter of operationalising it, and that clearly is not an accountability of SAGE.
Right, I'll move on. I'm not totally sure I completely understand that. If I can ask the question that Greg asked in a sort of blunter way. Everybody's been clear that the decisions that were taken would damage people's health because of the withdrawal of health services and of the economic damage that was done. There was going to... Again, did you, as the government's chief scientific advisor, recommend that there should be a paper that tried to quantify that across different areas? Because basically when the decisions were being taken, you were deciding that people who had onset cancer, people who needed transplants were going to die. I mean, it's as simple as blunt as that. Did you say that we should try to model this and work out the numbers?
We definitely flagged that the economic risks to health were significant, and CMO flagged that on numerous occasions, and that was well understood by Treasury, and we have pulled together groups of economists and epidemiological economists to talk about measures for preventing spread which take into account both economics and epidemiology with a number of meetings. I don't think we ever said that somebody needs to crunch those numbers on the economic side. We did, however, ask for a piece of work on excess deaths taking into account the economic impact. So that was commissioned as a piece of work for SAGE.
And has it been done?
Yes, it was done, yeah.
Because in order for the government to make sensible decisions, I mean, the excess deaths at the moment look at it to be about 65,000. They need to know what the other side of that equation is. And I would have thought it was the role of scientific advisors to say, at the start, this is likely to lead to so many deaths because of direct infection, and then this is going to lead to so many deaths because the health service, or large chunks of the health service, is cut down, and poverty kills, basically, if people lose their jobs.
Yes.
And was that up?
Yeah.
Was that quantified?
Yes, there was a piece of work done on that by the National Statistician.
And what were the numbers?
I can't remember the numbers off the top of my head, but the National Statistician did a piece of work on that for SAGE, and that's, I think, must be in the public domain already.
Right. We'll find that.
Move on, Graham.
Okay.
So okay, we'll go to Aaron, then you've got a couple of questions on
I've got a couple of questions on testing, but we can come back to them.
Let's come back to that. So Aaron Bell had something on monitoring and surveillance, I think.
Thank you, Chair. Yes, just to talk about the current monitoring and surveillance, Sir Patrick, what's the current time lag in our values for the country as a whole and for individual regions? To put that into an example, are we already able to detect the effects of the relaxations that we made on the 4th of July?
Time lag for the R values that are published is roughly 2 to 3 weeks because they rely on a number of inputs, including hospital admissions, ICU, deaths and so on, of which there's an obvious time lag. So the R is a lag indicator. There are ways in which you can do R which are more concurrent. So, for example, there's one particular approach run from another school of hygiene and tropical medicine called COMIX, which looks at contacts. So it's not looking at outcomes, it's looking at a contact survey, which gives you a more proximal measure of R. And the ONS survey, which is measuring infections, gives you, again, a more proximal measure of R. So it depends which value you're taking. The other thing I would say is that as numbers come down and are much, much lower, R becomes progressively less useful as a measure for the simple reason that it jumps around a lot with a few cases here or there or an outbreak, and it becomes really not a very blunt and lagging tool in which to judge effects.
So in terms of communicating with the public, is overall prevalence at a given time a better measure for people to understand what's going on with the current decline and potentially the future spread of a second wave?
We think prevalence, incidence, outbreak measures, those sorts of things are more relevant going into a lower overall prevalence state than R or growth rates are.
And given those time lags you spoke about and the alternative measures, what's our best early warning signal of a second wave? Would that be through that data that you've just spoken about, or are we going to have a time lag before we realise that we might be in a second wave?
No, it's looking for things like increased number of positive tests as a proportion of total testing, sort of thing that was done in Leicester. That's exactly why the Joint Biosecurity Centre was put in place, to be able to monitor those sorts of numbers through test and trace, and use a number of... what we recommended from SAGE was a number of different data streams should be used to look at this going forward, including that, but you could imagine other things as well, such as monitoring absenteeism rate and so on, gives you early signals as to where something's happening. But at the moment, it's based on testing.
And are those data sets and data streams, are they some of them publicly available, all of them publicly available, or is it mostly private?
I think the intention is that they should be public, but again, that's for JBC and Test and Trace to comment on.
Okay, thank you very much.
Thank you. I'll turn to Catherine Fletcher next, but just on the R number. Have I got this right in that if we get to a position, say we have one person infected with COVID in the country, and they infected 5 people, perhaps they're on the Isles of Scilly, the national R number would be 5.
Correct.
And yet, so therefore, it seems to me a poor guide to policy. What you want to know is the prevalence, the number of people, where they are, how containable it is. Why has R had this iconic, almost mythical status?
Well, it did early on in the epidemic because it was the right thing to measure there, and as you may have noticed with the language I've used at the podium several times, it's not the right thing to be using now, and it's been true in every country. I had an exasperated call with a colleague from Germany who was talking about how he was being asked to give R values every day and how they jump around and don't make any sense. And the latest bit that we've got on our website is low case numbers and or a high degree of variability in transmission across the regions mean that the estimates are insufficiently robust to inform policy decisions. So we agree.
Very good, thank you. Catherine Fletcher.
Hello, Sir Patrick. You've been at this a good while now, since half 2, and I am aware that it's not in the quietest 4 months of your life, so I very much appreciate your time. I was hoping to pick us up from where we currently are to look at treatments and vaccines, and to understand what SAGE's view on the likelihood is of those, and what we can look forward to as additional measures apart from just transmission spread. So if I start with therapeutics, is SAGE working on anything in the therapeutic space, or is it again just receiving data and feeding that in?
Can I give you my views and the views of other scientists who are feeding into this, because there are specific task forces working on this, and these are not topics which are coming to SAGE. So SAGE is not
Yes.
looking at specifically at
that would be
therapeutics or
helpful.
vaccines. So on therapeutics, where we are as of today is that we've got one antiviral, which obviously has some effect, which is remdesivir, which seems to shorten hospital stay but hasn't yet shown a decrease in mortality. You might expect that if that were to be used earlier, it's possible its antiviral effect would show some bigger action, but that hasn't been done yet. And then dexamethasone, which was the outcome from the recovery study, which does reduce mortality in patients in hospital requiring oxygen therapy. And there you get a sort of 25% or so reduction in mortality, a very important finding which can be applied across the world. There are more studies to read out. So there are studies from generally existing drugs that have been repurposed for this, and those should read out over the next few months, which may give further examples of where you can use drugs to try and reduce mortality. And then there are new drugs coming along. So, for example, there are antiviral drugs which are now much more designed for this virus rather than the other ones which were designed for another virus and have just been tried on this one. So there are protease inhibitors and messenger RNA polymerase inhibitors which are coming along, which may have a bigger effect. So in the therapeutic space, a lot to be done. One of the things that we need to do in this country, I'm absolutely sure about this for winter, is to make sure that as many patients as possible are enrolled in clinical trials, because that's the way we get the answer. It's the way we found out hydroxychloroquine didn't work. It's the way we found out the way that dexamethasone did. So clinical trials, very important for winter. Vaccines.
May I just, I apologise for interrupting you, but I think it's worth actually highlighting what a remarkable effort the British public have made in participating in these trials to date, and how they're contributing to science that is not only helping the British public but the world. I'm sure you'd want to put your thanks to them on record as well.
Absolutely, it's brilliant. I mean, the recovery study had over, I can't remember exactly what the numbers are now, it's 12,000 or more patients enrolled. It's absolutely impressive, and that's people volunteering to be in trials, which is a fantastic sacrifice to say, yes, I want to help somebody else by being in this trial. That compares with, for example, the WHO Solidarity study, which is a multinational study, which I think has currently enrolled about 6,000 people. Incredibly impressive that what's been done with the recovery. Vaccines, there are, I think, over 100 vaccine projects across the world. And there are some that are in the clinic and are leading. And the one which is at the front at the moment is the vaccine from Oxford, which is in phase 3 clinical trials in thousands of patients. That's a fantastic position to be in, and the UK has got itself well sorted out, and I was very involved in this at the beginning and stay close to it, in making sure we've got a wide range of vaccine options with different mechanisms, different approaches, because we don't know which one's going to win, or indeed whether more than one will win. All you can say is, and this is a bit gloomy, but it's true, the most likely thing for any single vaccine programme is it won't work.
Catherine?
So you need to make sure you've got enough of them in order to do it. And I think we're in a pretty good position.
Well, just let me understand very quickly, when are you making any assumptions about any one of those multivariate bets coming off in terms of the way the scientific advice is being structured to government?
Well, the Vaccines Task Force, which Kate Bingham leads, is absolutely looking at what are the options, what are the modalities, where are they in the proof stage, how far advanced are they, what are the manufacturing implications of this, and how does that feed through also into vaccination policies. There's a very integrated approach to looking at the overall options and making sure that we get the chance not only to be part of testing them, but also, of course, access and application of these vaccines. Doesn't mean we're going to get a vaccine, doesn't mean we're going to get one soon, but we've got the bets covered, I think, in a very strong strategic way. We're giving ourselves the best chance of getting something.
But our approach right now is not making an assumption that something's going to appear over the horizon.
No.
We know we're well placed for that, but we're planning as if we don't have it.
I think our assumption is we won't have it, and then when we get it, we'll be thrilled.
Thank you very much, sir.
Thank you, Catherine. Before I go to Dawn Butler, on vaccines, you mentioned the Oxford study is conducted by the Jenner Institute, I think. The director of the Jenner Institute today has called for challenge trials to take place, in which healthy young volunteers will be deliberately given coronavirus after receiving the vaccine. And he said that if challenge trials can safely and effectively speed the vaccine development process, then there's a formidable presumption in favour of their use, which would require a very compelling ethical justification to overcome. Do you share that assessment?
Well, human challenge studies for vaccinology are well established. So there's nothing new in that concept. It's a well-established way of testing vaccines. What are the two big challenges for this virus? Dose and rescue. So the prerequisites that you need to have to do human challenge studies are to understand what dose causes a safe infection, and can you rescue it if you get it wrong.
And what's the current answer to those questions?
We don't know the dose, and we don't yet know that remdesivir will rescue the infection.
So not yet is...
So I think absolutely the right thing to explore, but we're not there yet in terms of having the answers, and we need to make sure we progress safely in terms of understand. And you won't know the dose just because you can dream it up. You need to find out the dose, but there are ways to do that, and you can test whether remdesivir could rescue. But those are the things I think which are going to be the ethical considerations that people will need to think about.
And work is going on to be able to answer those questions.
Yes.
Thank you. Andrew Griffith had, I think, a brief question, and then Joel Butler.
I think when you spoke to this committee previously, I was certainly left with the impression that therapeutics might be more proximate and more likely than a vaccine. A vaccine sort of at that point was the moonshot, therapeutics was potentially down the road. What else is going on in therapeutics?
Well, just a word on vaccines first of all. I think it's also important to recognise the chances of having a totally sterilising vaccine, i.e. one that 100% protects you from this, I think are low. Much more likely that you have a vaccine that reduces the severity of illness and reduces spread a bit. So I think that's the more likely outcome on vaccines. On therapeutics, as I said, I think there's a lot going on now in two main areas, or maybe three. One is how you deal with the inflammatory response, which are the studies which should read out relatively soon, and there are more starting there. Antivirals, which I've mentioned two classes which are being pursued, and there are many others as well, and then potentially preventative medicines as well, which are being looked at. Those are the three big buckets, and they're all being looked at. And I think it's right that the therapeutics is more proximate. We've got dexamethasone, we've got remdesivir, and we'll see what comes next.
And what's the intervention? Sorry, Chair, just so I understand the work that Kate is doing on the vaccine side, and I think various witnesses have given us a good sense that almost every stone is being done, and Sir John Bell's leading a lot of work about how we do that. On the therapeutic side, is there an equivalent of that initiative, or is it by its nature much more
It's different. I mean, again, just to be clear, it's Kate and the Vaccines Task Force that's leading the vaccines work. Yeah. I mean, on that. On the therapeutic side, it is different. Because the issue with vaccines, and the reason we set up the Vaccines Task Force, was because vaccines require manufacturing capability in a way that's a bit different. They have a different need in terms of clinical trials, and in a way, you're more likely to end up with something that can come through different routes like academia than you are with some of the drug things. The drug things are largely in the area of big companies and innovative SMEs and so on with therapeutics. So they will come up wherever they come up. The manufacturing's a different issue. It's really about trials. So the question there is, can you get the trials right in order to be part of getting the answer?
Okay, thank you.
Thank you, Chair. Thank you, Sir Patrick. Talking about vaccines, actually, we took some evidence, and it was really quite interesting to hear that we are ahead of the game in any other country. Health literacy is absolutely vital in regards to fighting coronavirus and the spread. People understanding what their role needs to be in fighting this virus. And I just wanted to know your views on a couple of things. Number one, ensuring that we have all information translated into various languages. That includes British Sign Language. We know there's 11 million people in the UK who are deaf and hard of hearing, and now that face masks are compulsory, they won't be able to lip read. And also we understand that the UK government's virus task force has 47,000 British, Bangladeshi and British Pakistani volunteers. And I'm just wondering your views on making sure that all of the information is provided in different languages to help the science and to help combat the virus.
Yeah, we've said, and our behavioural science subgroup's been very clear that that is absolutely essential, and have gone a little bit further to say that many of these things need to be co-created with those communities. In other words, it's not the translation problem, it's actually how you get proper co-creation. And the third thing is that I think very often community leaders need to be engaged with this as well, because it's not simply a sort of information, I've given it to you, it's done. It's an engagement process. So we strongly agree with that. And the report from the Academy of Medical Sciences, I think, made a very important recommendation, which is that there needs to be a strong and comprehensive public information and engagement campaign in early autumn in preparation for winter. So strongly agree with your point.
And the face mask, people being able to lip read when face masks are widespread?
Well, I don't know what the answer to that is. I mean, it clearly is a big, one of the many big issues. There are others as well. So, for example, I've had colleagues, respiratory physician colleagues, who've spoken to me to say that their patients who've got chronic cough for other reason find themselves being stared at and shunted out of shops and things because people think they should be at home isolating, whereas they've got a reason to have a chronic cough. So I think there are some quite important things to look at here in terms of how we deal with all of these areas and how we make sure that we don't end up with people being selectively disadvantaged. And it's striking and incredibly depressing that this virus has not only exposed inequalities, but it has exaggerated inequalities. And that is a very important thing for us to keep in mind in everything we do.
Absolutely. Dawn.
And just one practical question. Mobile testing units. Should we not have mobile testing units at large workplaces where there are, say, 1,000 people or so, or 500 people? Would that not help in regards to understanding the virus and how it spreads? And if you take Parliament, for instance, we do have an issue with potentially creating super spreaders. And so having a mobile testing unit in Parliament, even if it's just an ad hoc basis, will help you in tracking and tracing if there is an outbreak of virus.
So I'm in favour of testing in occupational settings. As I said earlier, I think there are occupational settings that do benefit from testing, and we have also asked for a piece of work to be done looking at transmission in different environments. It's going to be led out of Health and Safety Executive, but with academics involved as well, because one of the surprising unknowns, and is we don't really understand the routes of transmission of this virus, as I said, and so we've got to do much more work to do that, and occupational settings are a good place to do that.
Thank you. Thank you.
Thank
Dawn.
you, Chair.
I think Graham Stringer had a couple of questions on testing.
Yeah. Thank you very much, Sir Patrick, this afternoon. You've drawn the short straw, getting twice as long as you were.
Yes.
But it's been very, very interesting. I've got a couple of questions on testing, but you just said something about a major public information campaign this autumn, which I think is important. Do you think that should also include a major campaign on flu vaccination? Because if we get a major flu outbreak, it will make things worse. And similarly, or along the same lines, do you think there should be an intensified campaign to get the lifelong pneumonia vaccinations, which are given to the over 65s, which may help with this? And sorry, this is a long question, it didn't mean to be. And should we intensify the pressure on care homes to make sure their staff are vaccinated for flu? Sorry.
Well, they are. I mean, we're going to sort of agree to differ on operational points, but these are important questions. And on the flu vaccines, we flagged up a long time ago that this needed to be a big flu vaccine season. The HSC understood that and have, I think, taken steps to procure vaccines. You don't procure vaccines now for winter, you procure it several months ago. Yeah. So this was something on our radar right at the beginning to say flu vaccination this year is particularly important.
When do you start vaccinating people?
Oh, not now. No, it's later in the year.
When?
But you need to
September,
you need to put the
October?
order in now in order to do
But
it.
when
So it's
does
a
that
normal flu vaccine. I can't remember exactly when the programme starts. It's sort of autumn time, late autumn. That the vaccine
late autumn
programme starts. So that I think is understood, and the Joint Committee on Vaccination has given advice on what the vaccine group should be, who should be vaccinated. And they've looked at the whole breadth of vaccination. So I think that is covered, and you're right to raise it. It's very important.
Thank you. Obviously, just going to testing for this particular virus, the virus has to be done a sufficient number, and it has to be accurate and of sufficient quality. Do you believe that the polymerase chain reaction tests are good enough?
PCR is very accurate, no question about that. But that doesn't mean the test is very accurate. So what do I mean by that? We know that you get false negatives, and those false negatives can be quite high at certain times of the infection process. So there are three main reasons for false negatives. One is it's early in the infection and the person isn't shedding enough virus to be detected. The second is that the swab itself hasn't been done adequately. And the third is the PCRs are false negative for some reason. And of those, the PCR false negative is by far the lowest. I mean, that test is pretty sensitive and pretty good. So it's really swabs and timing which are really important. And you can see, if you do it at the wrong time. So if you test somebody, after a few days after they were infected, before say day 2 or day 3, I can't remember exactly off the top of my head, but it's a sort of 30% or so false negative at that point.
That's very high.
But it's not the PCR. The other thing that's quite exciting is new technologies coming along, so-called LAMP technology, which allows a much faster and easier test, which is essentially measuring the same thing as in PCR. And I know there are studies going on at the moment to see if you can pick that up from saliva, which would make things much easier than the swab.
Well, we need extra capacity in the autumn when children go back to school and the weather changes?
Yeah.
Can you put a figure on it?
I don't know exactly what the figure is, but we need to continue to ramp up testing. I mean, I can't remember where we are at the moment. It's I don't know exactly what the numbers are. It's I think at least 200,000 a day, I think, and it's going to go up higher than that. So we need very high level testing, and that's why something like LAMP and saliva would be really good. If it was very easy and you could do it quickly, you can then really think about much more widespread testing.
Right, thank you.
Thank you, Graham. So just on that, you mentioned, Patrick, the Academy of Medical Sciences report, and that made the point that as we get into the winter, people are going to be presenting with symptoms that may be COVID, or there may be other types of, it might be flu, and therefore need to be tested. And they put a figure of, I think, over 350,000 people a day being required to be tested. Have you made an assessment of whether we've got the capacity to meet that?
Well, we haven't got the capacity to meet it at the moment.
We haven't?
At the moment, no.
Have you seen a plan to develop it in a credible way?
I believe that plan is being developed.
Because otherwise we're back to where we were in March.
It's essential. And the other question on this is whether you can what's called multiplex testing, so whether you could do something to test for multiple respiratory viruses at the same time, which would then allow you to say, you've got flu, you've got flu plus COVID, you've just got COVID, and triage much more effectively. And again, this comes back to the economic point, which is there's a very big risk with multiple respiratory viruses circulating that you end up isolating a lot of people who haven't got COVID.
Absolutely.
And because of the false negative point that we've just discussed, just because you're negative doesn't mean you haven't got it. So that's why isolation is important. So multiplex testing, where you can also get a positive on, yes, that's flu, I think becomes quite an important part of this.
I said right at the beginning of our session that part of the point of asking these questions is to be able to learn lessons that inform decisions on the way. And this seems to me a classic case of this. You know, the one thing that we've learned is that we didn't have enough testing capacity early on, so it needed to be rationed, it needed to be confined to hospitals in the first place. So this seems to be a matter of consensus now. So we must learn that lesson and apply it to make sure we have more than enough testing capacity in time for the autumn and winter, must we not?
I completely agree.
And do you think that is fully understood and being acted on?
Well, it's fully understood and it needs to be acted on. And again, you know, it's, as an advisor and as SAGE, I can't make that happen. But I think it's important that it does happen. I believe it is happening. I recognise that is a crucial thing to do. I've talked to you about multiplex testing as well as another thing. I've talked to you about the LAMP approach to try and get a more widespread testing. I don't think anyone's in any doubt that getting the testing right is important, and it's a fundamental reason why funding organisations like PHE and JBC is crucial. And if you look at the countries that learnt the lesson of MERS in 2015, they funded those systems well. And other countries around the world that saw what had happened funded those systems well. So the funding of our public health system is a very important part of preparation, not only for this, but for future problems.
And the responsibility of that, as you've made clear during this hearing, is with NHS England and the Department of Health and Social Care, and we'll have the Secretary of State and the Permanent Secretary next week, and we'll be sure to ask about that. But my the final and related question is that early in the pandemic, the committee took evidence about the projections, the modelling projections as to the number of cases that we would have, and obviously one of the pivotal judgments was whether NHS capacity would be swamped, whether it would be exhausted. Have SAGE made that same assessment of where we are for the coming winter?
Well, as you know, the Academy of Medical Sciences report, which we commissioned, has done that, and it's made some assumptions around that, and we're in the middle of doing further work on that at the moment. The one thing I'd say about the Academy of Medical Sciences report is they made an assumption that R would be 1.7, just as a sort of modelling assumption. And of course, that is literally just an assumption. So we're going to go through and work and see, make sure that we've got that ready for...
We read in the newspapers this morning that there is investment to be put into the Nightingale hospitals. Are we to infer from that that the normal capacity of the NHS is not going to be sufficient, so we can expect a caseload that is in excess of that standing capacity?
Well, I think it's reasonable to assume that you need, I mean, to be resilient, it's sensible to have that. We don't have any prediction at the moment as to what the numbers are, and of course there are other catch-up things that the NHS is dealing with as well. So I think, again, those are really questions for the NHS, but I mean, it seems to me entirely sensible to think about resilience in the system.
Absolutely, thank you. And it's been very helpful to understand the where SAGE can give advice and where it is not appropriate. So to give a final example of this, does SAGE give advice on, for example, whether it's safer to be in an aeroplane than a theatre?
We would not give that sort of comparative advice. What we would do is give advice on the principles of environments and how one should do a risk assessment in environments. It may be then health and safety executive or somebody would be able to take that down to the exact level of this environment versus that environment. What we have done, though, is a piece of what we've asked for is it possible to measure COVID security in an environment, which is very difficult to do. So we are looking at what the true assessment of that might look like, and I'm not optimistic you come up with a very concrete answer.
Sir Patrick, you've been very generous with your time. We're very grateful. I want to reiterate what I said at the outset. Our purpose in this inquiry is to try to draw lessons that can be of value during the pandemic and beyond. The way that science proceeds, and your eminent colleagues practice this all the time, is to ask some difficult questions and to produce some answers that may require a change of practice. Right from the outset, you've participated in that spirit. Very grateful for your continued engagement with the committee and for the very important work that you do on behalf of the country with those of your colleagues. Thank you very much indeed.
Thank you.
That concludes the meeting of the committee. Order, order.
Committee